Today I just want to talk about who liaisons are and where you're going to see us when you're working in the hospital. So the liaisons, we're a group of nurses and we have an office in the atrium, room 2104, so where that play structure is, that's where our office is. And there's 5 of us in there. So if you have any questions about home and community, that's where you're going to want to pop by. So I'm going to talk about who we are. So we are the connection between hospital and community. So we actually are under the umbrella of community, but our office, like I said, is here at the hospital. So when we meet for STR in the mornings, you will see us, we're generally sitting, so if you're looking at towards the back of the room, we're sitting on the left-hand side of the back of the room by a computer there. So that's where you can find us in STR. So the role of liaison, like I said, the bridge between community and hospital. And if you're not too sure what that means, so some of the things that we do is when someone is going home and they just need a little bit more support. So maybe they need personal care, so someone to help them with showers or baths, or maybe they say to you, hey, I'm really forgetting to take your medication. That's a good time for us to get involved. If they are going home and they are going to be palliative in community, then we connect them with the palliative team in community. So that's usually the home care nurses, it's also the palliative physicians, and then they get the support for palliative. If they're going home with a wound, then that's another time that we would get involved. Or let's say they're still rehabbing and they need to work with occupational therapy or physiotherapy, then we can refer to the community team and then they can go and support them at home as well. Social work is another great one. So if someone has some financial concerns or maybe some housing issues, that's a great time that you can refer to us and then we can put that referral out to social work. Some other services that you might not even know about is CVC, which is Community Virtual Care. They are a great program, and actually patients can self-refer, so they just kind of follow from a distance. So that's like a phone call. Let's say someone, they're on cardiac meds and they're really having a hard time balancing their fluids and their blood pressure medication, so they'll monitor things like weight, and they'll be like, okay, you're actually really going up in weight, so maybe we need to get more diuretics on board. They will connect with the physician and say, hey, these are some trends that we're seeing, and they will get them connected with the physician, and the physician can reassess their medications and maybe up their dose of Lasix or whatever. The other thing that we do here in hospital is we get people placed for long-term care. So when it's been decided that someone can no longer safely go home and we've exhausted all options, then we will waitlist them from the hospital. And it is quite a process. And as you probably already know, a lot of A side is all people, or a good majority of people waiting for long-term care. So that's where liaisons come in, as we do those assessments. So I just wanted to walk quickly through this booklet. This is the Let's Get You Home. So when somebody is admitted, you should be reviewing this booklet with them, and it's actually a really great book because it kind of does all the dirty work for you. And what I mean by that is those difficult conversations are really nicely summed up in this booklet. So if you go to page 1, it talks about why it's important for them to get home, that they heal better at home, less chances of picking up other illnesses here in hospital. So that's a great section for them, because quite often it's not so often the patient, usually it's a family member that is kind of putting up barriers as to why they can't go home. So this is a great way to kind of say, well, hey, this is the best place for them, really. And then on this page, it talks about that we gather as a team, and the whole team kind of discusses where they are at, and if occupational therapy is happy with them, physio, and the doctor's happy, and everyone's kind of given their approval, and they are discharged, and family or the patient is refusing to go, then it actually does talk about the acute rate. So this is a really nice thing to have, because that's a difficult conversation. Otherwise, that's usually Jean or Kelly or Isabel going and having those conversations with the family. So this kind of pre-warns them, hey, if you don't go home and everyone's decided you're good to go home, we can charge you the acute rate. And then it gives them a really nice discharge list, some things to prepare for. And then that's where we get into community services. So it talks about what community services are available. So it talks about case management. Those are also a group of nurses who will assess for long-term care. They help get home supports going, home care nurses, so they would deal more with your wounds and your palliative care. Rehab, we talked about. Nutrition, we do have a dietitian now as well in community, which is great. GSS, if you've ever seen Kelly sitting in STR, she's our current GSS, so she does a lot of seniors assessments. And then social worker, CVC, like I talked about, the community virtual care, and then subsidized home support. Now that's important to note, subsidized home support. So all these other services are free. Home support is actually not free. There are a few situations where it is. So let's say they're a person with disability, they're on PWD or GIS, Guaranteed Income Supplement, then they would be exempt from any kind of fees. But for everyone else, they do actually get charged for home support. So when you're like, oh, no big deal, you can get home support, do know that there is a cost associated with that. So the lowest rate is $35 a day, and the highest I've ever seen is $85 a day. So that's something to consider. That's a lot of money in a month if they're getting supports every single day. And then this kind of talks about private services. And I'll actually give you a handout about private services as well. This kind of talks about the cost of community services, which I will go into later. And then this is also talking about keeping our staff safe. So if they do decide to get community services, our workers have the right to be safe. So let's say it's a home where it's very cluttered, or there's people doing drugs or whatever. We have the right to refuse care if it's unsafe for our staff to go in. So it also warns them about that. So this is a great little booklet. So if you go over this with your patients at time of admission, it kind of clears up those things right off the hop. So please refer to this. And if you have discussed it, just chart it in the handover or in annotations or wherever, just say, reviewed it with the patient. And then we know, okay, they already know. None of these things should really come to as a shock to them. Then let's just talk about this one real quick. So this kind of talks about how home support is set up. So they do their best to accommodate people and adapt to their preferences and whatnot, but it's really difficult when they're seeing so many people in a day. Mm-hmm. So first, actually, let's talk about what we do provide. So we talked about personal care. So they come in the morning and they'll maybe help them get dressed in the morning, maybe help them get ready for bed, maybe do some toileting, give them medication, and they will do simple meals. So they'll warm up meals that are ready to go. They will make like a sandwich or maybe some porridge, but they're not going to sit there, making stir fry or cooking up a roast and potatoes. So they do need to know that. Some services that we don't offer, and this is quite often when we as liaisons will go have a conversation with the patient because the nurses come up to us and said, hey, they really want home support, and then we go and talk to them and they're like, yeah, I need someone to come in and clean my house and take my garbage out. We don't do that. I'll give you some phone numbers you can refer to for people that will come out and do that. They do have to pay for that service. So you can have those conversations ahead of time, and they're like, well, actually, all they want is this, and I know community won't do that. And then we don't have to go and have a conversation with them because you've already had that conversation. And then this talks about the home support binder. So when we go and we assess these people and we come up with a care plan, we put the care plan in this binder. Well, we don't do it, but we create a care plan, and then that gets communicated to community. And then community puts the care plan in this binder, and this binder actually lives in the patient's home, or we call them clients. So if you hear us say client, we're talking about the same thing, patient, client. And this has their care plan, which I will refer to this a little bit later. So very important that good communication and that we know what the care plan is, because this is referred to by a lot of teams and created by a lot of teams and a lot of input. So that's the home support binder. And then this is the times. So this is another important one, and this is where a lot of clients get frustrated. because when we say that they're having a morning visit ranges from 7 to 11. So if they're like, well, they're coming in at 7 o'clock in the morning, but I don't get up until 10 o'clock. They do try to accommodate, they'll do their best, but they have to see all these people. So they do their best to come when it's your preference, but they also can't always accommodate. So this just kind of lists off all the different visiting times. So when you say bedtime, that's anywhere from 7 to 11. And then again, it talks about the cost of home support. So I will tell you how that is kind of figured out. So let's say it's a husband and wife, and the wife now requires home support. We actually look at the income of the wife and the husband. We take that from the notice of assessment, we plug it into a computer program, and it comes up with the amount for us. So I don't know exactly how it's calculated. Thank goodness the computer does. So, and then that'll tell us how much it is per day. So like I said, the lowest is $35, the highest I've ever seen is $85 a day. And then this here talks about a backup plan. This is another one that's important. So everyone who does get home support needs to have a backup person, because unfortunately our services do get canceled quite often, just like here. Sometimes they're short-staffed, people are sick, could be bad road conditions, could be due to weather, and then we have to cancel services. So they need to have a backup person. And the backup person is someone that home support calls and says, hey, we're canceling services, can you please have so-and-so fill in? We're not going to be able to make it. Quite often, and we're seeing this more and more, people don't have a backup person. So we need to know about that, because we need to try really hard not to cancel their services, or we just need to maybe do a wellness check if we know that no one has been able to go and assess them or go and see them. So that's something that is really good for us to know as well when we're creating these care plans. So that's kind of the home support. This is a brochure that is in our office if you ever want to give one to your patient, but it is also one that we go over with them as well. Okay, so I talked about what is included and what is not included. I just want to give you this sheet as well. This is great. So these are services that clients would have to pay for, but it's got a lot of things on it. So it's got respite, it's got cleaning services, laundry, hairdresser, driving. So if they need transportation, that's on their meal programs. So this is a great reference sheet, and I find I'm handing this out more and more just because our system is so bombarded that sometimes you gotta kind of say, here, if you're able to do any of these services or look into any of these services, please do. Now I want to talk about charting, actually. So a huge role where the nurses come in, and that is with charting. So when we are creating a care plan, or when we're doing a long-term care application, we're always looking at those patient handovers and annotations. Those are hugely helpful. So when you're writing, and I know as a nurse, you just think you're kind of communicating from one nurse to another, and that's what those handovers are. And that's true, but you're also communicating to an entire team. I know social work reads those notes. I know the rehab team looks at those notes as well. So make sure that when you are doing those handovers that you do include things like if they're up through the night and they're needing toileting, how they got to the toilet, were they incontinent, were they sundowning, were they calling out all night? And you can write those in an annotation too, wherever, either or, but we do read those notes, and then it does help us create a care plan for them. And even once someone is, I'll talk a little bit about long-term care. So when we're doing a long-term care application, it's a lot of assessments. So we come in, we have a lot of assessments that we need to do, then we compile it all together. Family also has to be involved, so because we have to do a financial on them, so that they know how much it's going to cost when they go into the long-term care facilities. So we run the financial, we find out how much it's going to cost for them per month, and we submit this all to long-term care access team. So they review it, and they look at it and they can say no. So they can review it and they might be like, I see that you actually haven't tried this or that. So let's get them home first. I've never actually been turned down, but I know they are getting a lot stricter. So we submit the long-term care application, the team reviews it, and they either say yes or no. Then they get a wait list date. So that date puts them in queue. And then the family has 1 month's time. So from the date that they get approved for long-term care, family has 1 month, or whoever, to get finances in order. So maybe they're renting an apartment. So family has 1 month to cancel the apartment. They have 1 month, like I said, just to get finances in order, because after that 1 month, the patient waiting here for long-term care does start getting charged for that hospital bed at the lowest rate. So the lowest rate is $1,466.20, or a daily rate of $48.20. And it goes up every single year. So this is for 2025. So the people waiting here for long-term care are actually paying for that bed. And a lot of people don't know that. But like I said, they do get that month's grace before they start getting charged for it. And then when someone is waiting in hospital for long-term care, we have to give an update to the long-term care access team. So again, we're going back to your notes, so the handovers, to the annotations. So I know it's hard, especially when they've been here for a long time. You're just like, status quo, waiting for long-term care, blah, 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 no one cares. But we really do read those notes. So the more information you can give us, even if it does feel a little mundane, please put them in there, because we do refer to that. What else? Okay, now let's talk about home care nursing. When is a good time to let us know when they might need home care nurse to follow them? So let's say they're going home with a Foley catheter and this is new to them. We might want home supports involved, because if the family is nervous about emptying the Foley, then we want to get home supports involved to do that until they're more comfortable. Also, home care nurses are most often the ones who are changing the catheter every 6 weeks. So let us know if they're going home with a Foley. The other thing we want to know is when it was inserted, because we're changing them roughly every 6 weeks. We also want to know what size. So make sure that that's charted as well. And a nice place to chart that is in the informal communication. Is quite often our go-to spot, is where we'll look. Also, if they're going home with a PIC, we want to know the measurements of the PIC, when it's getting changed, and if you can put that in the informal communication, that's super helpful. If they're going home with a fentanyl patch and you don't think that they're able to change it themselves, we do have a team who will actually go in and change their fentanyl patch every 3 days. So we also need to know when their fentanyl patch was last changed. So if you know the fentanyl patch is new and you don't think they can do it, please make sure you talk to us, because we'll get that organized. The other thing is, are they going home in insulin? This is often a barrier to discharge, because they are not able to give themselves insulin. So we need to know if they need help with insulin. If they need help with insulin, our team can only do it once a day. They can't do sliding scale. They're not going to come out and do it 3 times a day. And that's if we can even get someone to do it once a day. We're actually really struggling to accommodate the insulins right now too. But luckily in Port Alberni, there's a lot of new pharmacies popping up, and they've been great. They'll go in the once a day, and they have been doing insulin administrations. I think that's about it. I think that's all I really wanted to talk about. If you have someone who's kind of humming and hawing, they're like, well, maybe I want home supports, I'm not too sure. This is a number that they can call, and they can actually self-refer. So they can call this number and they say, hey, you know, I'm kind of struggling. I thought I could do better, but I'm really having a hard time remembering to take my pills, or I can't bend over and put my socks on, or whatever. Then give them this when they're discharged, and they can call this number at any time. And it doesn't have to be for them. They can actually refer a family member or a friend as well. So this is a great little handout to have, and we have tons of these in our office. And then I will just mention this one on behalf of rehab. I know they're going to be doing a chat as well, but this is another thing to kind of watch for, is if rehab is involved and they've arranged, sometimes they do a pre-discharge visit. So sometimes they do it with the patient, sometimes they do it without, and they need to have them prepared to do that pre-discharge, or maybe transportation's been arranged. If you see this on the front of your chart, make sure you take note of the time, because there's nothing worse than the ride shows up, nothing's been packed, they're still sitting in their pajamas, they're not ready to go. So do watch for this one on your chart as well. And hopefully I covered everything.
Are those the sheets with all like the phone numbers? Are they somewhere on the unit?
They are not, but I certainly can put them on the unit, because yeah, that's a very handy thing to have. Yeah. Was this helpful?
Definitely.
Was there some things that you
100%.
guys didn't know?
Lots.
Yeah.
The community virtual care, is that like a phone call a day, or what does that look like?
It depends. So I guess they would kind of call, I don't know a whole lot about that. They would talk to the client and they'd kind of figure it out to see what their needs are.
Yeah.
But quite often, especially if you're looking something like cardiac meds, I'm pretty sure that would be a daily phone call. And I know it goes into the system. They actually have the patient do their blood pressure, and then it goes into a system, and then the nurses can actually watch trends and stuff. So yeah, it's great to be followed, and then they can see like, oh, okay, things aren't looking good, or things are looking great.
Yeah.
Yeah.
Cool. Another question. Sorry. So what, like, you said there's a lot of things where like people can refuse to provide care because of whatever reason. Would animals be involved with that? And then also, like, what about service animals?
Good question. Well, that's a really good question, actually. So we do have a rule that pets need to be put away when the workers come, because we have had a lot. In fact, we just had one recently where someone was attacked by a dog. We did talk about that one in STR, actually. So pets are supposed to be in a separate room because they like to be around and they would get nosy and whatever. They like to see what's going on. And they don't trust strangers sometimes, right? So pets actually are supposed to be separated. They're supposed to be in another room. With a service dog, I think that would be a different story. That's a good question. I'll have to look into that, but I'm pretty sure that they can be there. Yeah. Anything else?
That's great. That was fantastic.
Yeah, thanks for coming here.
Thank you, Tanya.
Yeah.
You did a really good job explaining that.
I hope so.
Yeah, it's a lot of information like in a short
is.
period of time. You did an awesome job.
Good.
Yeah.
Thank you.